Dr. Kinney, we see you in the lab.
On the Wi-Fi, are you?
I have to tell you, we're amazed of how you wired that last case beautifully, and the beautiful result that you got on that incredible triple turn circumflex calcific, unbelievable work.
Oh, really?
Can you hear me?
Thank you. Yes, I can hear you.
Oh, good.
If they can
The
have
panel
slide
is
of
in
case
place.
number
We're
6.
right on time, and let's see what you got. Live case number 6.
Yes. Live case number 6. This is a 70-year-old male. You have the panel?
Yeah, everybody's here. We have Dr. Let me tell you who's on the panel. Dr. Chandra, oh no, sorry. Dr. Barman, Dr. Fox, Dr. Moreno, Dr. Ichapuria, Dr. Kurtane, Dr. Stone, and Dr. Waxman.
Good to see you, Anu.
Good. Hello. Yes. So case number 6. So and you see myself, Joe Sweeney, and we have a fellow Vishal and Yash here. Will and Alina are the nurse, and Asif is our tech. And of course, Kiski will be here if you need any imaging. 70-year-old male with a lot of risk factors, which include diabetes, hypertension, smoking. And he had, everybody has a CTA now with a calcium score of to almost 2,800. And you can see your numbers, hemoglobin A1C of 6.6, LDL 85, CRP was less than 3. So he actually presented with chest pain and angina class 3. So he had a cath earlier part of May when 3-vessel disease was diagnosed with a high syntax score. So he met the surgeon, heart team discussion was done. He refused bypass. PCIs of the other vessels were done. Today he is here for the LAD. It's if I wanted to show you the picture, you can see EF is good. This is where we are with this LAD. Calcific. So you have the large diag. After that, it's totally occluded. And then look at his proximal LAD also. Significant disease of the prox LAD. So this was an ideal case for bypass. You see that? His circumflex, total, LAD total, met the surgeon. And this is how we are going to work on the LAD.
Turn down bypass?
All right, well, before we hear what you're planning, maybe we have the panel here. We have lots of people with a lot of experience who could tell us a little bit about how they might approach something like this. Now, maybe I could start with Ajay. Ajay, you're on the...
No, it's a great case, and I think that under the way you presented it, ideal case for surgery, especially with the OM occlusion as well. That OM is a very, very large vessel too. I think the way that you've proceeded is really important to do it with, duals. Oftentimes, you take a guide on the right side as well because of the retrograde options to that LAD, but it's not unreasonable for safety's sake to say we're going to try primarily antegrade wiring. It's somewhat of a blunt stump. It's hard to tell exactly where that comes off. You're going to want to wire the diag first, and then it's a perfect case actually for IVUS guided to see what it looks like. We always say that, but it's actually harder to do in practice unless you actually have a lot of practice doing it. So but it's a good case for that. I think that this should be wireable, and if not, you can do dissection reentry just beyond where the cap is.
So your strategy would be an antegrade approach first. Is that right?
Yeah, I think because it's short. You have to study the retrogrades more, but it's kind of mid to distal LAD, and most of the proximal septals will get you before where you want to be, so you have to kind of go more distal in the PDA and then back up, and that's sometimes harder. So I think it's worth a try antegrade first, but then be ready to go retro if needed.
Let's hear from Dr. Barman. Nitin? your approach?
Gotcha, yeah. So I agree with a lot of that. Obviously, it's a very ambiguous proximal cap. Before even getting to that, I would add, the idea of the revast strategy to, in cases with the CTOs, to approach the CTO first. If that fails, you can have a repeat conversation with the patient. But from an interventional standpoint, I think an angle catheter may be useful as well. I think this idea of IVUS-guided identification of the proximal cap, again, sounds great. I've literally never been successful doing that. So I think, again, it is a short occlusion. I think that if you just get a channel started in a reasonably close direction, many times the calcium can help you, and the calcium score was quite high, but I think in that region it doesn't seem particularly calcified. So retrograde, I'd be a little reluctant. I'm always a little reluctant right to left, and quite distal, so I'm not sure.
So you're good with this approach. Dr. Stone?
Yeah, I mean, I would approach it this way too, but I'm also wondering, I'd like to look at that circle a little more. I mean, the patient apparently presented suddenly with class 3 angina, suggesting that one of the occlusions might be acute. And I didn't see the circumflex occlusion that well. I mean, the LAD does not look acute. I mean, I agree with everybody. It's an ambiguous proximal cap. But, that being said, I would do this IVUS-guided, one, to identify the proximal cap. By fluoroscopy, it doesn't look like the calcification is that severe. You barely see it in the LAD during fluoroscopy. But I would also, use intravascular imaging to decide about lesion preparation strategies.
All right, Dr. Kinney, tell us what you're doing.
Okay, so agree with everybody in the panel, all the discussion that's happened so far. So let's, going back to Greg's question, that a culprit vessel was a RCA. That's what
I
then,
see.
yeah.
I'm sorry.
Discussion, we took care of that, yes.
I see.
Good.
Okay.
And let me go back and show you the circ here. Look at the circ.
There's actually, so it's not.
Actually.
Yeah, there could be a
there's-
microchannel there.
Yeah.
Yes.
I mean, there's at least some place to start.
Right.
Would anybody not do this at all and just do the right and the circ and leave this?
I think that the LAD,
Okay.
the LV
The
is,
EF's normal, right?
EF is like
65%,
65%, so. I didn't see a viability study or anything like that, but the LV is
The EF is normal,
working
you
well,
don't
and
need
the
it,
EF
yeah.
is normal, so there's some hypokinesis, but the EF is normal. What's your wire, AK?
So, I took the fielder all the way to get the microcatheter there. I have a Corsair. And now I should go with a stiffer wire. I don't know. I just took a Miracle 6. It's not doing anything. I'm going to quickly change. The question is, do I go to Gaia versus Confianza directly? Because I need to hook. So if you see, let me go back. I can tell you what I think. Where is the channel? Where is the... If I stop here, can you see? Almost that is where the cap, I think I need to enter. Are you able to see something there?
I know maybe it's overlap here. What about the RAO coral? It looked to me that in the RAO, the LAD look a little bit
Or an
easier.
LAO.
You have RAO?
Yeah, here.
Here?
Yeah, I just saw it very over here.
No,
That doesn't help,
It's hard
but
to work in the LAO.
How about
See
in an
the-
LAO? Could you see anything in an LAO?
Confianza 9.
Yeah, it's just after the septal, the origin. See, I think the key here is to engage the total occlusion properly with the feeling, with the tactile feeling, so you don't dissect the diagonal. Because what happens sometimes is, unfortunately, that can happen, and then
Or placing a wire in the diag and IVUSing that to see where the entry is on the, where
Yeah.
exactly you need to enter if you can't see
No,
it.
die here. Die.
I mean, the
The
view is-
calcium's a little helpful, so I think
Yeah.
that's probably why, but the problem is the calcium
That,
ends
I think
right
you're
where
already in the
is.
diag there. It's
where
probably,
is, the septal is above where the Corsair is.
The view is obviously critical, but a lot of it's empiric, whether the wire catches
No
or
doubt.
anything, and I think I'd have a pretty low threshold to.
Okay, I think it looks promising now.
It is promising.
Yeah, that looks promising.
You're in the right direction. And there was a channel there, so
She got it.
here you are.
So this doesn't look like a CTO. Okay.
No.
Like there was a channel there.
And you got a PVC, so you know that's alive.
Oh, that's true. Some die.
You can make a retrograde injection.
Do it, right.
See.
Yeah,
Greg, we may have found your acute on chronic.
Is that the Miracle 6 still?
No.
No, I
This
went
is
to
the-
Gaia. I made a little extra curve on the Gaia.
The Gaia 2?
Andrew, can we show some of the wire
So
from the guide wire slide?
the point that Anu made is so important because the Gaia comes pre-shaped with a 1 millimeter bend, and that's great when you're in the CTO. But to get to that point, that you definitely need the secondary bend, which is what she did, and that's how she was able to do it. So it's a really, really important point.
The true lumen, huh?
Nice job, Anu.
Thank you.
Looks true lumen, yeah.
Just curious to see what people on the panel are doing. Should this had dissected, what are you doing now for dissection reentry? You've got a couple of new products on the market. Anybody have any success with that, or still sticking with something like a Stingray?
I mean, we've definitely had success with recross, and some people would start with a dual lumen, but the problem with starting with a dual lumen is it's kind of hard to get the tactile feel for the conventional dual lumens. The advantage of that one is that you actually can go through the central lumen and do it in a reasonable way. So that's a reasonable catheter, and then obviously Stingray is tried and true, and then there'll be newer catheters as well that allow the hematoma management.
What do you want to get us a rotawire? And then
Rotofloppy.
what should be the burst size here now with that calcium? I mean, most of the calcium is in the prox LAD.
Yeah.
How's the microcatheter going down?
Yeah, slow and steady. You see
Slow
that?
and steady.
Yes.
That's a Corsair
You can
Pro?
see my Corsair, yeah.
Probably at the distal cap
Guide is,
right about now.
Yes, I could probably change the rotawire now.
I think regarding the
Get me
burst
the
size, obviously if the catheter doesn't cross, I think a 125 is reasonable, but you've taught me this, that in this region especially, there can be bridge segments that may not be appreciated that are particularly susceptible to rupture. So I think generally speaking, maybe downsizing the burr.
The thing also we have ready to go is a laser. That if microcatheter would not go, this is a case where we could do laser. Knowing that our wire crossed easy and
It's
there was
moving.
no dissection re-entry. I think we are good now. I can change the rotawire.
I mean, a laser is always the one you use if obviously you can't get your microcatheter down, you can't swap out for specialty wire.
Pretty good.
If it was just the
You want the
proximal, I probably would favor 175, but because you're probably gonna have to go into this lesion, I would favor 1.5 to start. I don't know. Anu, what was that your thought for Rhoda, 1.5 or?
I think 1.5, no?
Coming up.
Yeah, let me take this here out. 1.5 may be a little bit aggressive, I feel.
You can always go smaller. The mistake is to go too big up front. So
I'd start with a 1.5.
Okay. Let's go.
It's a pretty
1.5.
large,
1.5.
large LAD. I think you'll be fine with the 1.5.
I'd almost be worried that the
Well,
1.5 might not be big
it's-
enough for the osteo LED. So if you were going to do two anyways, I would probably go 125.
Depends on the wire bias. The question from the audience is, can you manage it with a balloon? And I'll be honest, I'm not sure you need atherectomy in this LAD. I'd love to see intravascular imaging.
yeah, no, and that's
Because by fluoroscopy, I mean, most of that calcium you're seeing right now is in the circumflex. You don't see that much.
No, look in the
no,
LED.
it's there. It's there.
There's a lot of
So,
calcium.
but Greg,
a little
this is,
extrinsic, though.
Greg, this is.
yeah, there's some calcium.
There is.
But Greg,
there
this is why
calcium.
we're doing Eclipse, right? I mean.
Yeah, no, absolutely.
Because I think this would qualify for, two sides of the vessel calcium. And we just don't know.
Two sides LAD, I don't know. I don't know if the core lab would call it that.
Good.
But either way, there's a lot of ways, and I think what happens, and there's a calcified case next, but there are a lot of times when people on panels that say definitively, well, I think IVL is a way to treat this, or atherectomy, or whatever, and a lot of times we don't know
Right.
that that's true.
Oh, absolutely not. So, for the audience, Ajay and I are running this Eclipse trial with orbital atherectomy, a randomized trial in 2,000 patients with severe calcification. So either defined angiographically or by OCT. So I think this patient probably would qualify.
You want OCT?
There might have been a different.
No, later.
With the CTO, I don't think so, right?
Oh,
No,
No, not with the, thank you, not with the CTO.
Yeah.
but we were talking about the more proximal.
Even I know that.
But just
I
the
included
concept, just the concept. So
But it is a good concept, as you said. I mean, what do you all think? I mean, we've been all morning talking about, you guys weren't here this morning, but we had 5 cases already with fantastic cases, and all of them was which device, and it seemed like it really, I'm not so sure that it mattered, and in some cases we had different opinions, and I think we're saying that intravascular imaging could help you a little bit, but in the end we
Get
saw
ready to test.
in one case with diffuse disease, everyone said rotoblader, and Dr. Sharma used the orbital atherectomy with no problem. So it would be interesting to see. What do you all think? To me, I think this is a rotoblader. Hopefully you could get it across. But what is the
Pull back a
panel
little
think?
bit.
John LaSala, what would you do here?
I kind of expressed that opinion this morning. The more densely calcified and the longer the lesion, the more I'm going to favor a rotoblader just because of the power that's generated and because it's a front cutter.
Good, okay.
But the vast majority of them, you could certainly go either way. I think that case that Samin did is an excellent example of that. Most everybody, as you said, wanted a rotoblader, but it wasn't prohibitive for orbital, and he went through relatively easy. You just have to be more patient. You have to recognize that you're going at a slower speed. You're not front cutting, but it will eventually get through there. You have to be cognizant of the fact that you don't want to push too hard, otherwise you can bend the wire and end up with a fracture, or the worst case, have the crown detached. So they both work. You just have to recognize the way they work, the speed they're moving at, and the differences in technique.
So you're ablating all the way from the top, yeah?
So, there was a proximal osteal LAD disease. I showed you in the column view. So, it was not, so the burr was not going easily. So let's burr that.
No, that was why I favored the 1.5, because I think 1.25 might have squirted through that and would have gotten the mid, but wouldn't have necessarily done anything up here.
And I hope you'll image after this run. I'd really like to see this vessel.
Yes, we will image. Okay, here.
But Rox, I think for the really, really tight lesions or a CTO, people like a small burr because, the shape really gets into it, a lot better than the OAS crown does.
For some reason
for
we
really
can't
big
hear.
vessels, it's nice. Then I like the OAS for really big vessels, unless you've got a lot of wire bias that's taking you into the calcified plaque with the rotoblader.
This is the most silent rotoblader stealth technique I've ever seen.
Yeah.
Can't even hear anything.
It's really silent.
Charlie Chaplin.
So this is the second lesion now. We went through that. Now the real test is for the significant disease, the CTO there,
And Anu, are you still using pecking technique in your lab? There's some labs that are now saying, Bill Lombardi's one, who's leaning more into the lesion, kind of like the orbital technique with a rotoblader. I haven't been doing that, but I'm just curious.
No, we have been doing pecking technique, and again this morning I think that's the step we showed. Yes.
Yeah.
Whatever you do, I still think it's important to prevent decelerations.
Yeah.
That's all it is.
We were really being silenced there. It's amazing. I've had patients say after we've done a rotoblader, says, were you working on my heart or were you drilling a cavity?
Drilling.
Wow. You see this?
Yeah.
Yeah, one thing that we don't see is the RPM.
Yeah, well, take your time.
You needed it, no?
It's going to go. It definitely needed it.
It's going to go. It's making progress. You just got to take your time, though.
I mean, you see the RPM, we don't, but it's also an indicator.
Also, pretty far down the vessel, you
we are at
may have to
150,
reset the burr to get a little better purchase.
The two main fear of rotational atherectomy is perforation and that the rota stuck. These are the two things that you want to avoid. All the rest is forgiven.
The 1.5 is less likely to get stuck than the 1.25, though.
The other thing we try to emphasize with the fellows is that the guide position and what you have for backup really, really affects how much force gets transmitted forward.
You have to have good backup.
What's
Yeah,
the
there've been-
speed now, Anu?
There have been times where I actually have my left
150
hand
now?
on the guide
Yeah, I
to
really
provide
think
further
I'm making
backup and then
progress,
push with the
you
right
can
hand
see
with the
some
reverse.
EKG changes now. Yeah.
Yeah, maybe undersizing is not a
Yes.
bad idea.
You see some EKG changes?
Yeah, I was watching, I was
Yeah.
just going to say something, and I
So I-
also see the guide
Okay, yeah.
also a little bit
I'd wait for
diving in.
those EKG changes to resolve before you go
Yeah,
again.
give her a little break.
But that's also teaching that when
Give a little up.
people don't know as much now, because with the move to balloon-based technologies, the whole idea of making sure that you let the flow to come back before you do another run is one that's really important to emphasize. So you see she's
think
very
another-
patiently waiting and letting it
take-
rest.
Laser.
And just
point.
wait, you see
Do one to
that
five.
lead AVF is really,
Get us a 125.
And give us a little,
I think
give us-
EKG is not getting better. I'm going to come out, okay?
Yep.
yeah.
give us a
I
little
see.
puff.
Yeah, I would take a little
And
puff.
then give some vasodilators,
Just
yeah.
wanna,
You got to know when to pull back.
diagonal should be okay, huh?
I mean, not getting through something, you can adjust things a little bit. You can, I've
Undersize.
often gone up on the speed. If the guide's backing out, as I said, use the left hand to advance the guide while you're going in with the burr. But at some point, if it's still not going, you got to come out and decide if you want to downsize or just default to balloon angioplasty.
Yeah, that was the point I was going to make, that a lot
Well,
of times.
the interesting thing in this case, though, is that I don't think the microcatheter ever crossed through that part, because if the microcatheter goes, then the rotavirus is going to go. So
Okay.
Only the nose was.
I think that's why the
Only
125
the
is
tip of the
probably.
microcatheter was in it.
And I,
The other
and I know
point is
to our CTO champions here that this sounds like bad form, but when I get a microcatheter down, I still like to do a little tiny injection through the catheter, just to see I'm interluminal.
Yeah, 125.
And that I don't have anything else in front of me.
You're
You can change
downsizing?
it?
Yeah, that's a.
Yeah,
that's a-
I'm going to downsize to 125 now, okay?
Yeah, the EKG is still not back, but take a look at
Yeah, I'm
also
going to
maybe
take a-
your guide.
Yeah, that's the thing. The guide is deep-seated, and then you have your proximal LAD disease, which is not helping us.
Yeah.
We won't routinely inject dye through the
looks pretty good.
microcatheter, but we'll give
looks okay.
nitride via the microcatheter prior to doing the rota.
You can always
I think
consider a laser
we did
also.
have some progress. You see some
Yeah.
flow in the LAD now?
Yeah.
Yeah.
You can
Maybe-
consider
maybe
a
you have
laser
less
as well
collateral
if it doesn't
flow.
work.
This is also one,
whatever
if
reason.
the EKG still looks bad, where you might want to think about, like a one
Yeah, I would-
one
I
five
would-
Takeru or something like that, or a one
I would switch to a
Sapphire.
balloon. I'd put a
I'm
better
going
wire
to give
down
some
and
more
switch to a balloon.
vasodilators, yes.
Flush.
We talked again this morning about you can put a microcatheter down and inject vasodilators through the microcatheter, improve the distal flow, but the bottom line is put a better wire in and balloon it up.
I mean, the fastest way, I think, is to put a small balloon in.
It won't cross.
I think it probably
Maybe
would.
the one.
Oh, the 10
the 10
Yeah.
maybe, but it's
10
gonna
or
be.
the-
What
Yeah.
will happen, I agree with Pedro in the sense that the microcatheter did not cross, actually Ajay mentioned that, did not cross the distal cap. So
You start
we
ballooning
may
proximally.
have
But I
trouble
think
in,
I think
not
you
with
got
balloon.
into the proximal cap, though, with the rotoblader.
Distal, yeah, proximal cap, yes, not the distal, and
Right.
even the balloon may not go. Now, 1.0 balloon, 1.0 Sprinter may, 1.0 Sapphire may make it there. But I think EKG is okay.
Yeah, it doesn't look terrible.
Almost 90% better.
Yeah, it doesn't look terrible.
The chances that the 125 won't make it as close to zero.
I'd go 1.0. I'd go with a 1.0.
Yeah, I'm thinking
That's
about the
one other
burr.
thing is,
Burr?
Yeah, the 125 will fix the.
I think the
the 125 will
1.25
go.
burr is going to work.
125 hours is going to work
perfectly fine.
great. It's gonna,
Yeah,
it's
I
gonna
think the
go.
1.5 would have gone if you give enough time, but with the ST changes, I agree with
It
changing
didn't go
plan.
because pushing the 1.5 will perforate, yeah.
Hold on. Clip on.
Ready? No, that's one. Other thing is this guy had presented with ACS, so this CTO may still have some thrombus there. It's having so much EKG changes. Ready?
Maybe you
we're
embolize a
going
little
up now.
bit, yeah.
Short total occlusion.
The other thing for procedural efficiency is that to do the balloon strategy, you'd have to go back down microcatheter, swap the wire, take a guide extension, go back in. So
Yeah,
this
that's true.
is
That's
probably
true.
a better way to go.
Wire back a little bit.
That's one advantage.
The wire is in the
OAS, when you
septal,
could be
we are
working
pulling
over a
back.
standard wire.
Okay, good.
Good.
Bullet shape. Yeah.
You can always tell a 125 angiographically.
Maybe you can dyna that glide down, that
The
wire down, yeah,
yeah.
good.
This will work. It must work.
Again, for trainees, you don't get enough practice with rota, but the idea of going on Dynaglide, defeating the brake and pushing the wire forward, that's a really essential trick
I
that
think
you
you
need to
did
know how
not
to do.
You get plenty of practice at sign
Elsewhere.
He didn't connect it properly.
And I know there are no Sinai fellows in the audience because they're all doing cases.
Come out, he didn't connect it properly. Okay, come out. One dyno.
Yeah.
Wire.
Yeah, I know.
Yeah.
I think he did not connect properly here.
Oh.
Yeah, that's the other
On the
thing. For
sound, I
good
can tell
support,
you
you
that,
really
yes.
got to be on the solid part of the wire. You got good guide support, and
Get
the
me a
wire's got to be
125.
distal.
A new burr.
What happened to the burr?
No, it was not
No.
connected.
It wasn't moving.
Stop.
Oh.
Get me a new rotor wire quickly.
Yeah,
New
there was some weird
Rotowire,
interaction that
rotowire.
was going on there probably.
Yeah.
So tell us what happened, Anu, I'm a little bit confused, and
No,
also.
so what happened
what's
is
that
we took the
guide there? Yeah.
1.5 bar. So when you change, there's a link. So you take the 1.25 and then connect the 1.25 link to the bar. So connection was not properly done.
Oh, I
Now
see.
you have it in the body and your link has separated. That's why I'm
Yeah.
trying to do rota and it's
Oh, very
you don't
good.
see the transmission. It's not being transmitted. Now when I'm coming out, what's going to happen? It's already disconnected.
Yeah.
Yeah, so the lock with it
yeah.
is
So the
a
wire-
lock
Very
and
good,
key.
very good.
And if you step on, if you activate it and you're all of a sudden you see you're up to like 240,000 RPMs, but the burr's not spinning, then it's been separated.
Yeah, the only way to fix that is if you can, in the guide, get a trapping balloon up, trap the wire, and then come out, because otherwise it's going to be impossible to take out without
right.
pulling the wire.
No,
We're going to try with the fielder.
But
What do you want?
fine cross or something you have, right? Where's the corset?
quick
Right,
share.
corset. So I'm going to go back with the microcatheter.
It's sometimes very difficult to link those two together
share,
because
guys.
if you're over the age of 50, you can't see it.
Okay, give us a fine cross. Where
That's
did you
not
put
a
the corset?
problem
You
for
have-
Dr. Kinney.
yeah.
49, no.
And Anu, you don't have to wear, you don't wear progressive contacts either. It's actually remarkable, to be honest.
Yeah, no, she has really good vision.
Okay, please, guys, don't put eyes on me.
Okay, so tell us, you're going to try it with the rotor straight up,
I'm
or
going
you're
to
going to
do
go
is,
with the?
primary rotor wire now.
cross.
I'll try to do primary rotor wire. If it does not, then I'll have to go fine cross. And we have a 125 bar again ready. Yes. Connecting it.
Get a fine cross ready.
This should not happen. But you should recognize it as soon as it happens.
That's the key.
Yes.
This is just a bare rotor wire Kinney technique.
But the drive, the new one though, the RotoWire drive, because actually, to be honest with you,
Yeah, unbelievable.
it's a big difference compared to the old stainless steel one. Nice.
Wow.
That's great.
Amazing.
Without support.
Good job.
Well done.
Very impressive.
No need for any micro
The old
catheter.
one would not have steered like that.
We don't need no stinking
Not at all.
No, we don't need no.
Don't try this
125
at
burn.
home.
Yeah, again, don't try this at home.
Did you try a 1.0 balloon?
No, but not
We
yet.
did not because I think we decided that we may have problem even with the 1.0 balloon getting across there. So we wanted 125 bar. So I guess we will get that 125 bar balloon.
We have it.
Yeah, I mean, I would
And
like
then-
to remind everybody that she wanted to use a 125 burr in the first place, and if
Yeah.
she hadn't listened to us, this
Right.
wouldn't have happened. Right, Anu?
Well, I don't know about that, because I think she wouldn't have made a lot of progress in that Prox LAD, like, because it was sort of, it needed that 1.5 burr to get through, so it's kind of
Ajay,
a.
She would have probably upsized to
No,
the 1.5
Prox
anyway.
LAD we could have done IVL if we needed.
Ajay,
But
what do
this
you
needed
mean?
1 to 5 bar.
Ajay, what do you mean by
IVL
us?
for the
I wasn't up here
proximity.
yet.
The other point that's, it's not really relevant
I mean,
here
the
is
way
that-
the wire went, the 1.0 balloon would have gone there.
is that the burr can get worn out over a certain amount of time. So if you're doing a long segment or 2 segments, you have to, I don't
ready?
think that's what happened here, but.
Cups on?
John, when you
Okay,
used
good.
to teach all the rota classes,
Ready, off.
how many runs did it take for the diamonds to get dull?
No,
We got
150.
them higher.
A lot,
Look a
right?
little up, but didn't seem obvious.
How many runs did it take for the
think that's a-
diamonds to get dull when in all the rota experiments? Because I will tell you, most people say that in the experiments it takes a lot of runs, but in clinical practice it seems to happen
I
pretty
agree
frequently.
with you. I think when the 1.25, it is the one that gets dull more often. For me, I just change it, and you can
And then it
tell.
works.
Yeah, and then it works, yeah. Now, you decided to use regular wire, huh? Like the floppy.
Sapphire wire is very low profile. A 1.0 sapphire wire will go
Become
in.
dull and you feel it, and then you get.
Diamond chips become.
No, this is what I'm saying. So
No, it happens. Yeah.
this is what I'm saying.
When,
is that
when it's not going, it's
when it
something
doesn't
wrong.
go,
Yeah.
it's kind of like the cath lab's superstitious. Usually, like if you can't engage one vessel, you call for the other catheter, and when you call
Right,
for the
and
other
then
catheter,
it
then it
goes.
engages.
Look at this. This is a beautiful,
Look at that.
beautiful device.
Superstition.
This is flying in.
Yeah, I think
Skating
a lot
through
of that is,
Okay, get me the run through wires. So I can
Run-through
use the
wire.
run through now.
you know, the more tapered tip and the more
Everybody's
shallow angle.
Everybody's got a slight difference in techniques,
Slow.
but if I'm using a larger burr like that and I'm stuck, first thing I do is go up to a faster speed. 150 is not going to do it.
yeah.
Gotta go
What did you say,
180.
John? What would you do?
I would go to a
Turn the
faster
speed up.
speed.
So,
Faster speed, yeah.
But John, the question
Dr. Kinney, is
with the
this your
EKG
next
changes,
thing?
you would have
Is
done that?
what?
Yeah, I
Are
think
you-
with the
Back to the
EKG
point.
changes
Could
are the
we have
concern. You're
just
already
done a
getting
balloon
platelet
angioplasty
activation.
here? We could
think,
have.
you know, one of the principles I learned many, many years ago is when you're doing a rota and you have ST elevations, continue with the rota and fix it. You know, when a complex rota, I think this is what we see today. You have to restore flow, and otherwise changing techniques is a complicated field.
You have a balloon?
I think though, Pedro, it depends a
No,
little
no,
on
no,
the
wrong.
cause. I mean,
Yeah.
if it's
There is
platelet
a
activation with
2520.
thrombus
2520.
and slow flow.
Dr. Kinney, you
you're gonna make
think,
that worse.
what is the next
Rotational
thing right
atherectomy.
now?
If you're dissecting,
I'm
that's
going
another
side by
Yeah,
ballgame.
if
side
you're
with the
dissecting, it's
rotor
another story.
I'm watching the time and I'm
with the
thinking we
run-through.
need to go to Dr. Sharma soon, but maybe you just tell us what's next here?
Beautiful.
No, we are going to take a picture
Let's
now.
see the
This is
Just
balloon.
get a
Let's see the
picture and get a
run-through
quick
wire.
image. If you can image really quickly.
Okay. Without imaging, Greg is not going to leave us, okay?
I know, I'm going to be very upset. I want to be very, I want to learn. I want to learn what this vessel looks like.
Now, the STs are resolved, Anu?
Yeah, yeah.
The STs are not
Yeah, a little
100%
bit.
resolved.
Still, they're not 100%.
they're
You see
not.
that? It's still there.
Yeah.
You're gonna protect that diagonal
I
or
think
no
the
need?
point to be made here was that should we have gone with the second burr versus balloon? Yes, I think Ron Waxman kept telling us balloon. We could have tried that, but then if the balloon had not crossed, then again we had to go back with the rotor. So despite when you do first rotation, rota burr, and then we saw EKG changes, we could have changed the strategy and say, okay, stop, and let's go and balloon it.
Yeah, I just wanted to make sure that everybody knows sapphire balloon are very low profile, and they usually were. And they come at 1.0.
So hold that
this
thought,
is a
I'll show you a case
bifurcation
in a
lesion.
few
It's
minutes.
the old Orbus niche.
Good. Go. Where we could consider just
Yeah,
provisional stenting.
open.
Let's see how the diag behaves now. Would there be plaque shift or?
It would be interesting
So
to
this is
see
a
by IVUS how
2.5.
much calcium is there.
Okay, get us a IVUS. Yeah, I
No
promised.
If you do
OCT?
imaging, we're not going to leave you.
This patient
this would be a
had
nice
normal
OCT.
creatinine
Oh, the creatinine was 1.3,
Okay.
yes.
1.3, but today became 2.0.
Okay, okay.
So we are hydrating normal EF, normal EDP. So we are hydrating a lot. We were planning OCT, but changed it.
Okay, okay.
To Dr. Moreno's point, though, a lot of times when you see ST elevation, it seems paradoxical. If I have collaterals, why do I have ST elevations when I'm working on a CTO? And the answer, of course, is that you still got a lot of particulate matter that can be generated and clogging the microvasculature. So the best thing is to just try to establish the integrate flow and improve in that situation.
An interesting concept that in the old days we thought doing a CTO will never harm a patient, and we learned the hard way.
Found out we were wrong.
Is your plan to also handle the circ today or no?
Oh, no.
No. With
Now with the creatinine
No,
too.
now
We
with the
can do,
creatinine
yes.
of 2.
Yes, yes.
This one's going to be staged.
So what we will do right now, I think the plan should be if the diag looks okay, provisional stenting.
Yeah,
Yeah,
for
totally.
sure.
And then we'll have to probably likely place a stent even in the,
Because it seems to me you got to deal with the proximal LAD as well, so.
You know, I would
Show
not
us
be
some of that.
surprised
Okay, there we are.
if the prox
Look at this, look how
doesn't need
easy it
anything other
goes
than
in.
an NC balloon.
Let's see the IVUS, please, on the main panel, please. We just have the fluoro.
Yeah, so with the creatinine,
Okay.
I will start to work. Anyway, it's two lumen. I was categorized in 2 lumen
Yep.
and coming back, kind of dark image. Yeah, not that calcified.
Oh,
Yeah,
that
now
might
come
have
to
been
the
a
before
nodule
diagram.
there.
Yeah. Oh, here is some calcium. So some dark image, sorry.
Deep
Bad
calcium.
quality.
It's
Some interference. It's
little
not
flush.
a flush issue.
Yeah, yeah, flush if you
Yeah,
can.
I will stop it. The most important is the catheter is in the true lumen.
he's saying virus in the true lumen. Okay, let's do the proximal LAD again, come back. He wants to make sure.
That's where the diagonal comes
there
in,
you-
so
you
it's
have a
just
little-
distal to that.
Yes.
You still have a lot of calcium there.
But it's deep calcium.
actually,
Deep and it's not
Go a little
circumferential.
bit, go a
That's
little
the
bit
point.
further in. Yeah, right there.
Yeah, balloon.
Okay, now proximal LAD, we want to re-IVUS the proximal
Yeah,
LAD.
yeah, because I think you need to see.
Yes,
Yeah.
yes.
Okay, I start to work.
There we go.
Coming.
with your
Eccentric
creatinine,
block. Lumen looks fine. Oh,
Yes.
sorry.
Not a lot
More
of calcium,
interference.
guys.
What's
Yeah.
happening there with the IVUS, guys?
Electrical interference on the
It's an
catheter.
interference of some electric interference.
Electrical interference. So go back. So
Electrical
the proximal LAD
interference,
It does have, no, 3/4 calcium.
Yep, not that. It's
a
like
big
a
vessel.
deep calcium.
Yes.
Yes.
I think if you take an
it's
NC
deep
balloon.
Back to
calcium.
the
It's-
ostium, yes.
Yeah.
This is going to
And there you are.
dilate fine. It's a
Yes,
huge
right
vessel, though. It's almost 6
I don't know, in that
millimeters. there.
distal area, I still think, I'm not so convinced that you're going
It's
to get
not
the
ready yet
best
for stenting,
expansion.
but you can
can't tell what's
you can
going
use
on.
cutting balloon here if you want to.
Let's take a picture. So I think what we'll do a cutting balloon of the
Yeah, I think.
proximal ostial LAD. We have to dilate more.
For sure.
Diag looks good,
Yeah, I
right?
mean, there you've
I
got
think we don't do anything in the diag.
it's
No,
We'll
no,
just
I
take
7
wouldn't.
milliliters.
The diag does look good.
this is another value with imaging, is that when somebody
I
has a
have no
creatinine
idea.
of 2, you probably don't want to use more than 75 cc's of
530,
contrast,
Yeah,
if
I
that
mean,
much.
there's the
So
worst
now,
calcium. and
once you
it's
get to
less
the
than
imaging
180
portion
and it's
of
deep.
it, you can delineate exactly how
It's
far you
deep.
want to go, with what diameter, and never use any
Cut
calcium.
away with a stent.
Before? Okay.
Come back to Anju.
Okay,
So we'll put a 2538 and dilate
Yeah,
the
Ajay,
proximal,
knock out
mid
this
LAD, and then ostial will
I
cut
think a lot of
and
the calcium
place
you're
another
seeing
stent.
angiographically was in
all
the
right, if
circ,
you don't
not in
mind,
the
we're going to
LED.
go to Dr. Sharma, and then we'll come back to you, okay? So if that's
Yes.
okay. Let's go to
No
Dr.
problem.
Sharma.
But I think that imaging was really
Okay.
helpful because it really showed you just need big balloons, big stents, and everything is going to push out of the way.